When the one-way valves inside a leg vein fail, blood struggles to fight gravity. It pools. The pressure builds, and the vein walls expand outward, twisting into the swollen, uncomfortable ridges we call varicose veins. After age 50, your body's ability to recover from internal vein damage slows as skin loses its natural elasticity, making it harder for the legs to heal. These age-related changes create a higher probability of developing venous ulcers or blood clots, transforming a minor cosmetic concern into a direct threat to your future mobility. Because of these physical risks, early intervention functions as a preventative health measure. However, patients immediately face a UK treatment market that is both expensive and difficult to navigate. Navigating your options comes down to balancing 3 strict constraints: how long you're willing to wait, how much you're willing to spend, and the probability of permanent success. This chart maps out the current UK landscape. We plot the financial cost of the procedure against the time you will spend waiting for it. Down here in the NHS zone, the financial cost is 0, but that price is paid in time, requiring an 8 to 18-month wait before surgery. Up here is the private zone. You get immediate access, usually within 2 to 4 weeks. However, the prices are scattered, ranging anywhere from £400 to nearly £5,000, depending on the clinic and the method. The dilemma is clear. The free option costs months of physical deterioration, while the cheapest private option might leave you with a procedure that ultimately fails. You might assume that a quick trip to your GP with aching legs will get you a standard surgical referral. In reality, the NHS tightly restricts access. This flowchart illustrates the hurdles for public funding. It starts at the NICE CG 168 guideline, which acts as a strict medical necessity gatekeeper. Cosmetic concern or mild discomfort will not qualify you. To pass this first gate, you must demonstrate severe symptoms, like active or healed venous ulcers, thrombophlebitis, or recurrent bleeding. Even with severe symptoms, your GP will require a mandatory preliminary phase, a 3 to 6 month trial of wearing compression stockings. If the stockings fail to provide relief after 6 months, you finally get your surgical referral. But you then hit the last hurdle, an additional 8 to 18-month waitlist for the actual procedure. Stockings manage daily swelling and aching through external pressure, but the internal structural failure of the vein remains. The NHS path is a test of endurance. Patients over 50 must live with progressing risks and daily discomfort for up to 2 years before seeing a surgeon. To bypass that wait, many look to the cheapest private option available, foam sclerotherapy. Using ultrasound guidance, a doctor injects medicated foam into the affected vein. The foam expands, causing the vein wall to collapse and eventually seal shut. The upfront inputs are highly attractive. It costs between £400 and £900 per session. The recovery is incredibly fast, with most patients returning to work the very next day and wearing compression socks for just a few days. But the low price comes with a major catch. At the 5-year mark, foam sclerotherapy has a massive 20% to 30% recurrence rate. Since 1 in 3 patients needs the procedure repeated, this low upfront price often traps patients in a cycle of recurring treatments and mounting costs. The modern clinical standards for treating varicose veins are thermal ablation techniques, specifically endovenous laser ablation, known as EVLA, and radiofrequency ablation, or RFA. These require a moderate financial input. Across leading UK clinics, expect to pay between £1,500 and £3,000 per leg. The physical recovery demands a bit more of your time. You will need to wear compression stockings for 1 to 2 weeks, and you must strictly avoid heavy lifting and running during that period. Most return to work within 7 to 10 days. This bar chart compares the 5-year recurrence rates, and it shows exactly what that extra cost buys you. While foam sits at a 20 to 30% failure rate, EVLA and RFA drop down to a minimal 5 to 10%. You trade a noticeable upfront investment of capital and a week of downtime for a 90 to 95% probability of a permanent, one-time resolution. We also need to address traditional vein stripping. It is the oldest surgical approach, and while it is less common now, it is still offered. It carries a high financial cost of £2,000 to £3,500 per leg, along with a uniquely harsh physical toll. You face a long 2 to 4 week recovery period involving significant pain and bruising. Despite being the most physically invasive method, its 5-year recurrence rate is 5 to 15%, which is actually worse than modern laser ablation. Traditional stripping maximizes both your physical pain and your financial cost without delivering superior longevity. To make a fully informed decision, we have to stop looking at the price tag on the day of surgery and start measuring the true cost over a 5-year timeline. This matrix maps upfront cost against failure risk. Top row, foam sclerotherapy, 400 to 900 pounds, 30% risk. Below, EVLA, 1,500 to 3,000 pounds, 5% risk. Applying foam's failure rate, repeat sessions quickly surpass a single EVLA treatment's cost. The NHS costs zero, but demands 18 months of health risk. The logic of the vein care matrix dictates that long-term value is defined by the probability of a permanent result rather than the initial cost or the speed of the first appointment. This decision tree maps your next steps. Strict budget and severe symptoms, your path is the NHS. Fast, low-budget cosmetic fix, foam sclerotherapy works quickly, but expect high recurrence. Over 50, valuing long-term health with 1,500 capital, your definitive path is EVLA or RFA. As your risks for ulcers and blood clots rise with age, prompt intervention is vital. EVLA and RFA offer the highest objective return, trading a moderate upfront cost for a near guarantee that your mobility is permanently preserved.